Hi, everyone, and welcome to today's Washington Wins. This month, we're joined by Earl Leach. I did it. I got it right. We've only worked together for I don't know how many years, and I struggle every time to make sure I get it right. So welcome, everyone. My name is Dawn Reinhardt Wood with Rutgers University. I'm joined by my colleague, Earl Leach. And today's topic is promoting personal safety and risk reduction in supportive housing settings. Next slide, please. So we'd like to take care of a little housekeeping before we get started with the webinar. We want to remind you that today's webinar is hosted by DBHR through the Washington State Healthcare Authority. This is an interactive training, and we encourage you to ask questions and participate throughout the session. The slides, as well as a link to the recording of this webinar, will be sent by email after the presentation. Okay, and we also want to make everybody aware that, excuse me, Rutgers University, in partnership with Washington DBHR, is conducting a Washington State Learning Community Study. As you see on this slide, there is a QR code that you can scan with your smartphone to participate if you like. We're interested in learning more about participant experiences from the landlord outreach, which is the Washington Wins webinars now, like you're in at this time, buried in treasures, the job developers, supported employment supervisors, and the supportive housing supervisors learning communities. If you're interested in participating in a follow-up focus group to our previous survey to share additional information regarding your experiences with participating in Rutgers University and Washington State learning communities, please use the QR code to provide your contact information. And if you'd like additional information about the study, you could reach out to our assistant chair, Nora Barrett, at the email that is provided on the screen. Okay, so let me just go through a few housekeeping points. We want to make sure that you understand that your audio and video are currently muted. You can use computer audio or call in. To ask questions or to respond to questions, use the chat to panelists and all attendees. So make sure, or it says everyone, where it says everyone, make sure that is selected, or not everybody will see your questions and responses. You can download the chats from the chat box if you would like to at the conclusion of or before the conclusion of this webinar, if you'd like to save the chats. Sometimes there's really fruitful information and a dynamic exchange in the chat. So if you'd like to record that, please feel free to download. Also, for accessibility purposes, subtitles are available. To see subtitles, click on More and Show Captions. And also, if anybody during the webinar has any problems with any accessibility concerns, please feel free to contact us in the chat, or you can message me directly. So just to let everybody know that the webinar is being recorded, and the presentation and recording will be shared at the conclusion of the webinar.
Thank you, Dawn.
Thank you, Earl.
Fantastic. So welcome once again. I haven't seen the folks in Washington for a bit, so I want to say hi to you all and hope that all is well. So we're going to embark on a discourse around a subject matter that is often talked about in the hallways or talked about amongst colleagues, but seldom really looked at comprehensively at the leadership level, at the planning level, the strategic planning level. But it's a major subject because the idea of really focusing on risk management and really addressing those concerns is significant to how we operate in our space, how well we are able to really embark on our day-to-day activities in a meaningful, thoughtful, safe, authentic way. So it's important for us to not only have the discourse, but have some sense that we are part of that planning process and implementation process and assessment process of determining whether or not we are really operating in the safest possible space. And we're doing everything we can to ensure that that is fortified and that is maintained for us. So I want to take a look at the outcomes we're hoping to achieve, or the takeaways we want to have from today. The learning objectives. We want to look at the definition of workplace violence and really examine its prevalence in today's work environment. We want to really look at the risk factors and the impact of workplace violence in the individual, organization, and the whole behavioral system as it stands, as well as really look at some interventions for prevention and management of workplace violence in specifically the supported housing settings. And as you may see, it may actually be broad-based enough to really impact all work settings that we have. So that's our ambitious objectives for today, but I'm certainly hoping that you get the main takeaways from today's engagement. So just, take the journey with me, and certainly feel free to share as much as you can so we're able to achieve our objectives for today. So we really want to start with, and I'm going to quickly want to make sure that I'm sharing my sound. Again, I just so you can let me know if you're able to hear the video. So I want to start with video option now.
Can you not do that, please? Thank you, Bill. And how are you today? As I was saying before, we got back your test results, and your UDS actually came back positive for cannabis.
Bullshit.
They are your results.
They're not my results. You can't even read, for Christ's sake.
Don't
bill me, you bloody moron.
You can't talk to me
I
like
don't
that.
talk to you as I bloody well
It's
like.
acceptable for you to talk to me like that.
I live here, not you. You come in here at 9 o'clock, piss off at 3 o'clock, you and all your damn nursing colleagues. You don't know anything. I feel like smashing those glasses. Just four-eyed idiot. I'm going to find out where your family lives and smash the bloody lot of them.
Occupational violence and aggression is a serious issue. Puts our staff at risk in any of our clinical settings, and we won't accept it.
Many of our patients have the potential to be aggressive or violent, particularly in the acute phases of their illness, but we have a duty of care to look after them. If staff don't report violent and aggressive incidents, then we have no idea what's going on in the workplace.
We have response.
So I wanted to start there because it's important for us to have a sense as to what it looks like, and some of us may have had the unfortunate experience of having to really be on the other side of it. And this is just one rendition of what it looks like. And to be quite honest, it's kind of an extreme rendition of it. But oftentimes when we think of workplace violence, particularly in our neck of the woods, in our field, it really reflects in a manner as seen in that video, as presented in that video. But we really want to get a sense as to how it resonates with us. Is that kind of the most common reflection, or the way it's presented to you in your work, in your workplace? Is that a familiar instant? Is that a familiar scene? First indication is every day. Fair enough. Yes, very familiar in the psych hospitals, right? Quite often, more often than we like in many regards. That's an interesting perspective. It's often a frontline staff that sees that. And that may be true in many regards. It's a regular occurrence. Fair enough. So it's just one of those things where we want to start where are we having the same conversation? Are we in the same, same space? And that's important to have a sense as to what that is. Great point, Phoebe, in that it's often over the phone. So even if it's not in your, face-to-face interaction, it can come in many forms, and we'll talk some more about that. But it's important to get a sense as to what that looks like in its most frightening stage, I can say possibly. But ultimately, how do we define workplace violence? What's kind of the most popular or foremost definition of workplace violence? The CDC, the National Institute for Occupational Safety and Health, defines workplace violence as violent acts including physical assaults and threats of assaults directed towards persons at work or on duty. Very simple, very concrete. Yet, as we know, it can present in so many different ways that sometimes it is difficult to find a all-encompassing, consistent way of defining it or even determining what it looks like. The U.S. Department of Labor defines it as an action, verbal, written, or physical aggression that is intended to control or cause or can cause death or serious bodily injury to oneself or others or property damage. So as you note, I started out with that just person to person and expanded, because that's what often happens. That definition sometimes is expanded beyond the scope that is normalizing for us, right? Because it's speaking to the intended or the intent to control or cause harm to oneself and to others. It's not merely pointed directly at staff alone or to consumers. It can be even self-inflicted in many ways, and we'll talk about that as well as we talk about property damage in that instance. So it's important to note that even the definition of it has variance and really can be, in many ways, either very limited or very large in scope. So how do you define it in your own space? How does your agency define it? Is there more of a slant on assaultive behavior? Is there more a slant on property damage? Is there even a consideration of self-inflicted self-harm? Is that considered violence or workplace violence? What do you find in your workplace as the foremost way of defining workplace violence? Someone says all of the above in your workplace. Hannah says harm to self, others, or property, also threats and posturing. That's an interesting one. That's the first I've heard of that, posturing, but I can see how that can be presented as a implicit threat or presumption of threat. Threatening suicide counts as actions, verbal or physical threats or actions. So, and that's it. Even in our workplace that may be similar or within the same confines can have such a varying perspective of it, right? Wow, that's an interesting perspective. And someone thinks that it doesn't take it as seriously as we should, like it's given that it's going to happen. Very common. Absolutely. We've recently had threats, workplace violence increase a lot, so they're still figuring out what it looks like. So there's some agencies where it's evolving, it's fluid. They're constantly redefining what it looks like. And yes, Sam, to your point, complacency can be a real issue. We'll talk about not just complacency, but the fact that we don't even sometimes recognize the risk factors that really speak to it. But it's important for us to have that concept in our heads that there's no single way of defining it, even if there's some standard ways of defining it. It's ever evolving based on what is occurring. Because there's even instances of terroristic threats that impact workplace violence. Or we'll talk some more or even look at relational violence that may enter into the workplace, consciously or unconsciously. So there's lots of scope of really looking at it from different perspectives. And Stephen speaks about power of management, define it, not those who are in direct contact. Yes, it can. People can see the differentiation in the definition based on where you are on the totem pole or on the ladder of power. It's an important point. Glad to hear that you are kind of in the same zone as I am in terms of seeing it in that regard. But for the general understanding, there's about 4 major types of workplace violence. There's criminal intent, worker-on-worker violence, client-on-worker violence, and then there's personal relationships. And once again, I want to make sure I reinforce that this is just the general, this is just the kind of formative way of looking at it. But there is no singular way. It's not static. It's evolving over time. But for general information, there's really 4 types that are really looked at from the CDC. And when we speak to criminal intent, we're talking about the perpetrator has no legitimate relationship to the business or its employees, and usually someone in the throes of committing a crime in conjunction with violence, robbery, shoplifting, trespassing. So those are instances where that is brought into the workplace without there being a legitimate relationship between the workplace and that person. It's more from an external concept. The client-on-worker violence. The customer or the client relationship includes patients, their family members, and visitors. So it expands even beyond our clients. And most frequently, these occurs in emergency room and psychiatric treatment settings, but it's no way it means it's limited to those elements. And I think most of you may be very much familiar with what those acts of violence or presumption of violence may look like as it relates to a client and worker. A worker-on-worker or a staff-on-staff violence is also a significant part of the workplace violence realm. And it's commonly referred to as lateral or horizontal violence. It includes bullying, verbal and emotional abuse, and even up to homicide. We've had instances where staff has gotten to the point where, they harm the other staff or their colleagues, and it results in a homicide. Then there's this personal relationships. This is often the one type that is often not really brought to the forefront or point of reference, and oftentimes it's kind of peripheral. But oftentimes that occurs when the perpetrator has a relationship with the staff outside of work that spills over to the work environment. And unfortunately, we have to accept that that is becoming more prevalent, or the instance of it is becoming more significant in its outcome. I can tell you from my own experience, I worked at a mental health organization in Virginia where one of my colleagues was actually killed on the job site by an ex-partner. And I can tell you, I'm still dealing with the trauma of that event. So, and to Don's point, domestic violence definitely fits into that category, even though it's not often discussed in that same realm. It is part of workplace violence. So it's important to see how they present in those realms, and yet recognize that it's not limited to those elements. Any question there? Does that speak to people's experience? Is that you're familiar with those elements? Are you commonly viewing it through those lenses? Or does your agency speak to it through those lenses? Because oftentimes what we find is that there's a conscious or unconscious limit set to workplace violence. We often speak about it primarily in the form of client on worker violence. We tend to limit that scope, whether consciously or not, to just clients intend to harm staff and not see it through that broader lens. So how does workplace violence show up, particularly in our workplace? We want to make sure we look at it through all its occurrences or how it may, the mode it may take. So we know certainly of verbal aggression. There's also many instances of written aggression that we often don't see in the same scope. You know, one of those letters or email or text that you get from a client, an ex-client, or a family member that is not just pejorative, but sometimes just downright threatening. And too often, we can make the mistake of just ignoring it or treating it like as an aside or something that is just par for the course. Yes, those hostile emails or even worker-on-worker bullying. And we can see it across all four of those categories. Where a colleague that you may choose or you may have made the decision not to help in the way they choose to get help, and they're threatening you with the next time you ask for help, ABC is going to happen, and what kind of person you are, or lots of internal strife that end up in workplace violence occurrences without us seeing it through those lenses. The extreme obviously is physical assault and threats of assault. One of the things we often don't really resonate with in terms of how it presents is serious bodily injury to oneself. There are instances where we have staff or clients who may be self-harming, whether it's intended to, derive attention, derive more services. Someone may be out of control, someone may be symptomatic, someone may be dealing with emotional issues that may not be addressed properly. You can have self-harming behavior, threats of self-harm that are associated as well with workplace violence. Damage to property. Whether it's that client that is telling you, oh, you don't want to transfer me to partial when I think I should, you better watch yourself when you come out in the parking lot, or you go outside and know that, your tires are slashed and you had that look from one of your colleagues or look from a client that told you that that could have possibly been the results of that verbal or non-verbal interaction. Intimidation, harassment. And we spoke of domestic violence and how disturbing and traumatic that can be. Instances where there's stalking going on. Sexual harassment that may result in stalking, or maybe the precipice or the predisposition that occurs in relation to staff-on-staff violence and vice versa. So it's important to understand the variety of ways it can show up in your workplace. Not merely as the picture dictates, staff being afraid of something coming at them from a direction that they think is a solitary or singular way in which it presents. So it's important to note that the variety and diversity in the way in which it can present. And as we spoke about, self-harm, one of the ways in which that happens that is often not recognized as such. But self-harm as an act of violence is part of the category of workplace violence presentation. And it's important to note the statistical value of it and why it's so significant. Because oftentimes when we think of workplace violence, we don't see the perpetrator and the victim as the same person. And they can be identical. It's important to note that suicide is the 10th leading cause of death, wherever it occurs, particularly as it relates to the workplace. And a great number of people have died by suicide in relation to workplace violence in 2020 as a point of reference. And that suicide rates are the highest among adults aged 45 to 64. And as much as they may not make up the largest component of our workforce, they're a substantial part of our workforce. So I really want to give you a broad-based, really in-your-face kind of representation of what it looks like so that we can have a good point of reference to start with this discourse. Does any of this surprise you? Or is this something that you're familiar with, or you feel like, you know, prior to this discourse you knew and you were fully aware of? Or is a lot of this information, particularly the manner in which it presents and the statistical aspect of it, is it surprising to you? Glad to hear that Rebecca says she's familiar with it. Interesting, Angela. She said, I didn't realize it equates with self-harm. And that was the point of reference. To really make sure we have a sense as to how it presents so that we're not ignoring it and not, you know, ensure that we're reporting it as such so that there's actions that's taken to really address some of those concerns. And Lorelli says, I thought suicide would have been higher. And maybe it is, because it's kind of ironic. We're talking about it as it relates to 2020. And, you know, we're going into the fourth year of beyond that. So it may be even higher than that. And particularly, and to Dawn's point, particularly high in some categories, in some professions. As we know, there's a great number of self-harm or suicide in the medical field. And in some other fields. It's great to know. So I think most of the responses we've got in the earlier parts of training with this is that people can't conceptualize it as such, right? Suicide is not conceptualized as part of workplace violence, but it is if it's impacting the workplace and if it's occurring with people who are either colleagues or clients or somehow connected to folks that you're working with. And absolutely, we'll talk about access to lethal weapons and other risk factors that impact that number. And Sabrina's point, self-harm is one we don't talk about enough. Yes, and there's reasons for that. You know, whether it's a cultural thing or there's a concept that we don't see it that way. Because we ask ourselves, why doesn't self-directed violence garner so little attention? And there's some specific, there's an answer that's kind of specific for it. As a society, we find it difficult to conceptualize self-harm and suicide as violence at all. And one reason for this difficulty is maybe that our prototype of violence is other-directed. We often see violence as being perpetrated upon us, as opposed to seeing it internal to our schema, into our world. Because when we think of violence, we have some classic images, right, in the movies and all the things, and most of the time it's occurring outside of us. So it's important to note the distinction there. So what's the reason why we're having this discourse? Why is it that important for us to talk about workplace violence? Well, the healthcare and social service settings account for 75% of almost 25,000 workplace assaults reported annually. Substantial number. And people who work in our field are 5 times more likely to be victims of workplace violence than other workers. And our field really accounts for about a quarter of the workplace violence instances. So there's a great risk concern, there's a great prevalence of workplace violence in all its forms presenting in our neck of the woods, in our field, in the workplaces we work in. And it's important to note that. And what I suggest, if you want to get some more statistical analysis and statistical information regarding that, is to check out the Workplace Violence in Healthcare 2018. The US Bureau of Statistics have that information clear to you. That is not to say I want you to be bombarded with that information to the point where inertia takes place, but it's important to know so that when you're making that point, particularly to your representatives and leaders, you're making a point with some an informed position. But the extent of the problem is significant, particularly in our workforce. What is also important is that even though we know those numbers may not truly represent the prevalence of the problem because there's a lot of underreporting occurring. And there's reasons why underreporting is such a significant challenge as it relates to workforce violence. Awareness. There's a perception, and someone mentioned it earlier, that workplace violence is just part of the job. You know, being at risk and getting threatened is just part of our day-to-day. We sometimes don't have the policies and procedures or training to report it. Or sometimes the manner in which it is required to report it is so taxing as it disincentivizes from reporting it. It's too much work for us to do that. It's time consuming. You have to go through all kinds of hoops to get that reporting in place. And sometimes we have to fear that if we do so, there's victim blaming possible here. That someone will see us as, crying wolf or trying to draw attention to our consumers if certain things are not occurring. Or sometimes it is even an instance where we believe that if we report it, no action is going to be taken and it's going to relieve us of that fear and burden. Because there's an instance, and there may be a single instance or many instances where you are faced with that, and then you don't see what you consider to be accountability for that violence from a client. Client may be back in the program the next day. And you feel like all your effort to report and acknowledge it's gone to waste. But there's a number of other reasons why there's underreporting. So even the numbers that we see are not truly reflective of what's going on. And there's a continuous reinforcement of the importance of reporting it without you using your own filter. Agencies should have standard operation practices, procedures to ensure that all instances are reported. So what are those risk factors for violence? Because if we understand what it looks like, we understand its prevalence, how do we know what to look for? How do we even get a signal? What is the smoke screen that gives us a sense that, hey, this is likely to happen here? There's all the instances and the formulation for it likely happening here. It's important for us to have a sense as to what are some of the things we need to look out for. What do they look like for us to get a sense that this may be prone to exposure to violence in our workplace? There's what is considered as static risk factors, right? Those are factors that we're unable to alter. They exist. They're part of the core of what we do. And that's history of previous violence, both for clients and staff and loved ones and other such instances. This may be, I was startled when I saw this, not because it spoke to what I consider to be the evidence, but the fact that it's just kind of resonated with me. Male gender is a high risk factor for violence. I'm like, oh, gee, of all the things, but it can't ignore the fact. Young adulthood. Sabrina, this is a good point. Is that stigmatizing? If taken in the manner in which it is seen as a differentiation, it can be, stigmatizing. But in reality, it's just maybe just a numbers game. But that's part of the reporting process. Even the consideration of intelligence, where that may lie. So some of these may seem pejorative, and I was kind of taken aback by it, but I'm like, okay, I just delivered the news. But it's important to note that. A history of military service. And oftentimes we think of that because of the trauma that people may go through and how they may not be addressing those, and therefore it may play out in high risk or high stress areas. Weapons training. And I know Don spoke to just having weapons available. Past diagnosis of major mental illness. So it's important to note them, but to see them in the scope in which they are presented. They are just indicators and factors. Then there are risk factors that are considered dynamic, those that may be changed or improved to improve the outcome. So those that we can impact, those that we can alter, those that we can kind of shift. Substance use. People experiencing persecutory delusions, command hallucinations, suicidality, history of suicidality, treatment non-adherence. Access to weapons, a significant risk factor. So it's important to recognize them, and in doing so, we can then, particularly for the dynamic factors, look at the protective factors that may be able to mitigate those dynamic risk factors. And oftentimes when we're assessing for risk concerns, we look at those risk factors and the protective factors simultaneously. So are some of these familiar to you? I know some folks have already said, hold on a minute, Earl, some of them look stigmatizing, some of them look stereotypical. How do you see some of these risk factors? What is your first kind of response to them? Because as we speak to them, I want to look at them and how they are really categorized as well, beyond simply the ones that we can address and impact and the ones that we can't. Very good. Yeah, they are important, and you'll see them, I think, more significantly based on the lens you're using. Because if you work in a psych hospital, if you work in inpatient care, some of these are just like straightforward and upfront in your face. If we're more removed from that kind of control environment, it may be different. And here he says, especially in social work, they're familiar and important to recognize, but not assume. Very important point. Don't simply assume that that's what it is, right? And yeah, most of them are general indicators. So now let's look at the risk factors in healthcare settings. So let's pull it into the setting, because we're talking about how does workplace violence is really associated with a specific work setting. So we want to look at client and setting factors. Working directly with people who have a history of violence and substance use or gang affiliation may engender more of a risk as it relates to the likelihood of violence occurring. Transporting clients is a significant risk factor, particularly if you're doing it solitarily. If you're doing it as a single person, and a person only transporting that person, a person may have a history. Or where that person is on the current distress, or the person may be symptomatic. Lots of instances where there's many instances of work violence associated with transporting people. And oftentimes it's taken for granted that transporting people during the course of work, if violence occurs, it is not considered workplace violence. It certainly is. You'll be shocked to learn that workplace violence even encompasses driving from your home to work. And Dawn spoke to the fact that she once had a woman experience tactile hallucination who tried to jump out of the moving vehicle. Went, absolutely. And those are some instances. Or someone is being taken to an appointment that they're not, truly want to attend, and they're forced to attend or be coerced to be in attend, and then you're talking to them about all the things that they haven't done and why they have been non-adherent, and that person just decides, I've had enough of this. You have me in this enclosed environment. I need to get out. So be conscious of that particular occurrence that can have some impact. Workplaces that have, poor kind of environmental design, where your vision is obscured and you're not able to see oncoming things. And the client may see this as, an instance where you're alone and take liberties with their actions, particularly if you have a conflicting relationship or you have strife and conflict going on. Prevalence of firearms and other weapons among clients and their loved ones. Those are some of the things we have to assess for. And what is considered a weapon? Working in neighborhoods with high crime rates, we can be exposed to robbery and threats, gang threats. If we're working, particularly in the substance use realm, with a client who's currently using, and you're trying to get that person, in recovery, the dealer may not take kindly to your interventions and your presence, and that could lead to risk concerns. Working in high needs, low barrier settings, absolutely. So it's important to understand those settings and the impact that they may have on the level of risk. Organizational risk factors. High staff turnover, which may lead people to two things. People may be more inclined to work in isolation. People may be more inclined to actually work without taking the necessary precautions. Or high turnover results in high stress, high work demands, distress at work. People are more likely to get aggravated, irritated with each other. And therefore, worker-on-worker violence may soar. So there's lots of ways in which that may be impacted. And there's the concept that the perception of violence is tolerated and that victims may not be able to report the incident to police or press charges, and therefore you just accept it as par for the course. And it sends the message to the client that it's okay because you're not reporting it, there's no action being taken. So there's lots of instances where organizational factors may also impact risk concerns. And I know a lot of this may seem like, okay, so what can we do? Given the fact that it's prevalent, it comes in all forms, we're still trying to get a handle on all the presenting ways in which it does. There's risk factors from the client setting, there's risk factors from the environmental setting, organizational risk factors. Earl, what do we do with this? So what do we need to know before we intervene, before we take action? There's some important elements to make sure that we are aware of, we're conscious of, before we jump in and take action like we're designed to do, we're conditioned to do, we're trained to do. We need to make sure that we're doing it from an informed perspective. So it's important to place violence in a context, because all presenting ways does not speak to the same element, right? In assessing for risk of violence, it is important to place violence in a context. It's important to note that under any circumstances, anyone can become violent. It's not limited to someone that has severe and persistent mental illness or someone has a history of violence alone. Anyone has the capability of responding in a violent manner, given the right factors and the right circumstance. And I use right not in a positive sense, but just to give you a sense as to how it may unfold. Self-control and the ability to really manage one's emotional distress may really be impaired if someone is under the influence of substances, or may be experiencing severe and uncontrolled symptoms that they're not really managing very well. What we find often as well is that often violence is a response to feeling that all other options are exhausted. You corner a client, whether verbally or physically, it may result in that person feeling like the only action they have, the only way of taking control and managing is to actually react in a violent way. And that's what we find oftentimes, that people's reaction in a violent form is really that definition or the distinction that they're feeling helpless and powerless. Clients that are mandated for service, and you spend most of your time establishing what they can and cannot do and why they're in this situation and all the decisions and choices that led to them being restricted. It's not a good place to start. You can't be surprised by the person reacting in a violent way, because you basically told them they are powerless. And as human beings, we have a natural instinct to exercise some degree of control of our existence in our lives. How we do so may be dependent on the circumstance or the degree of powerlessness or power that we have. So it's important to put violence in the context so that you're responding in an appropriate, ethical, principled way, in a way that actually can impact a change in that person's perception or the level of risk concerns. Now, we speak about the symptomology or the symptoms that may lead to violent behavior. There's lots of them. Once again, it's within a specific scope. It's not all-inclusive and it's not the only distinction, but it's important to note some of the symptomology that can result in violent behavior. And we spoke about them earlier. Hallucinations, delusions, grandiosity. Antisocial personality traits may have the propensity to represent and present in a violent manner. And what spurs a person to aggression or violence? It's not exact, but we certainly need to have a sense as to what it may look like so that we are cautious and we think of it in that scope. Recognizing aggression in its appearance, some of the physical activities, the mood, speech, staff reaction. It's important for us to recognize the signs of aggression. And there's great ways, there's great tools that can help us do that. One is STAMP, which is really assessing staring, tone, volume of voice, anxiety, mumbling, and pacing. That's a very good tool that really helps us see the initial indicators and the signs of aggression in our consumers. It can be an everyday occurrence in some of our workplaces. So it's important to recognize some of the clients or some of the behaviors that really exhibit that kind of risk-prone behavior, such as verbal aggression, self-harming behaviors, aggression towards objects or people. Those are some of the instances and signs to recognize, because in many instances, there are very firm indicators. So, for example, appearance. If someone presents as intoxicating, bloodstained eyes, carrying anything that could be used as a weapon, you have to have that conceptualization that it may certainly reflect higher risk concerns. If someone presents to you and they're restless and agitated and pacing, standing up frequently, clenching their fists or jaw, have hostile face expression, they have this, as you can feel it, that eye contact that tells you something is not right here. Or they're frequently entering on off limits or areas or their space that they're not invited to, may be indicators of propensity for violence. So it's important to know that. The same goes for irritable mood, anxious mood, stress, distress, difficulty controlling emotions. These are some of the indicators. Are any of you familiar with STAMP as kind of a screening tool, a visual screening tool for assessing and recognizing aggression and violence. Or are there other tools that you use in terms of recognizing aggression, physical aggression? Okay. So for those who are not familiar, it's great, something definitely to take a look at. And we'll have that in the resource list as well. And it's also it'll be on the PDF that you can click on the link. So even with that, we want to also take a look at how familiar you may be with the assault cycle. And this is something that may be more commonly discussed or addressed in the inpatient psych units as well. And that's great, Blender. Glad to hear that there's de-escalation training that is occurring and how you should react in those instances. So when we speak to the assault cycle, it's important to note that, there are 5 separate and distinct phases of that. The triggering event, escalation, crisis, recovery, and then the post-crisis depression phases of the recovery cycle. And even though it may seem like, oh, that's expert stuff to learn, or I'm not in that situation too often that requires that kind of expertise, it's important to know it so that you may be able to share that with a consumer, for the consumer to have some kind of internal reflection on where they may be in that cycle, particularly if they have a history of aggression. Because when we talk about the crisis stage, oftentimes that's what we see. That behavior pattern that explodes into one or more physical assaults or perceived source of stress. The individual may, threaten injury, hit, kick, throw objects at people. That's oftentimes where we see things occurring. But then there's the recovery phase subsequently. That we often see people having that kind of muscle relaxation. They become more progressive, relaxed. There may be a ritual that person engages in after aggressive behavior. And sometimes the person kind of over time, in some instances very quickly, kind of resort back to baseline function. And in some instances, people may have a history of getting there and then re-escalating based on some specific vulnerabilities. So it's important to have a sense as to that kind of cycle that may occur for you to be able to see, know, and kind of observe those instances as they occur and be aware as to what they are and what they may be signaling. So let's look at some specific interventions. But before we do so, we have a sense of how do we measure aggression. And there's some specific tools that are used. And they fall into that observation-based category and the self-reporting. So in many instances, we're able to use a lot of it. And once again, a lot of these are used in inpatient settings, but they are also just as applicable in outpatient settings. So there's oftentimes that historical clinical risk management assessment tool that oftentimes come in the hospital record. We have staff observation, aggression scale revised, and there's the modified overt aggression scale that gives us some observational basis, which means we can look from the outside and kind of get a sense as to how our clients present from a historical standpoint as it relates to violence and the propensity for violence. Self-reporting is some of it we can use with our consumer in kind of an interview process or give that person to fill out themselves. There are instances where it can inform that person as to how they present as it relates to violence for their own knowledge and for their own options or ability to kind of self-regulate. So there are tools that really can be used from an observational standpoint and together with our consumers to help really inform the process as to how we help folks manage and support them in responding in ways that does not necessarily result in a propensity or consistent violent manner. So it's also important for us, particularly as we work in this field, to prepare to respond to an assaultive behavior. And someone may ask, why do we have to do that? Because it's prevalent in our work environment, right? We need to be prepared to respond to assaultive behavior before we enter the client's space. Because there's no better stuff than to be prepared for something and it doesn't happen, as opposed to it happening and we're not prepared to deal with it. I like that, Emily. Emily says, always wear comfortable shoes for the obvious reasons, to skedaddle out of there when it's necessary. But proper attire is important as a preparatory strategy. How you are dressed, it impacts on your ability to respond during an emergency. If you are going to your client's home and you're wearing garments that you can't even stretch in, you can't run in, you can barely waddle down the road, it's not a good thing. Even if that person may not have had a recent episode of violence, you always have to assume that it's possible and react in that way. Wearing chains or necklaces, earrings that dangle to your shoulder, all these things that can be pulled, tugged, or can put you at higher risk. No flip-flops. Don't stand between you and the exit. There's many physical proximity as well as attire considerations that are important. Adequate mobility. Are you prepared to move quickly? When is the last time you actually were able to pivot, turn, move quickly? Are you in physical shape to do so? Do you have a well-developed observational strategy? Do you know what to look for? We just talked about some of the risk factors and the signs and indicators. Are you aware of them? Are you keeping them in the back of your mind, in the forefront of your assessment? Do you know your own limits? What are you able to respond to in a thoughtful, ethical manner? What triggers you? Regaining your self-control. And Steven says, I wore a tie my first day as staff in a shelter. Yes, we've all had that instance where we dressed to the nines the first day and the supervisor looked at you and said, where you go? I don't think you're not going to work in the field this way. But we were trying to make a good first impression. But we learn as we go along. And Brenda speaks about a client throwing rocks and damaging a car. Another significant thing, and we'll talk about that. Where you park in proximity to your client's residence, particularly based on the nature of the relationship you have. So these are just some ways to think and process as you prepare to intervene, even in the most practical way. We want to look specifically, as someone alluded to that earlier, guidelines for telephone threats, because oftentimes we just imagine that we all can manage a telephone or virtual threat easily. That's not true. Here are some specific guidelines as to how you do that. If a client is becoming verbally abusive on the phone, explain that their language is not acceptable and that you will terminate the call unless they refrain from such behavior. It is not appropriate to just hang up without giving a full warning and an indication, because that person may move from that verbal to physical presence. So let the person know, hey, Harry, you're angry. I'm trying to respond to your request for a specific service, but the manner in which you're speaking to me prevents me from being able to explain this clearly to you. And if you don't refrain from cursing at me, I would have to hang up as per policy and as per the manner in which we present our service. I hope you understand that clearly. Harry continues to verbally assault you. You said, Harry, I'm going to hang up as I indicated. I hope that we can talk at the time when you're less aggravated. Be firm and consistent. Hang up when you promise that that's what's the next step if the person doesn't change the manner in which you're speaking to you. In some instances, the person may put another person the call to call you subsequently, one of those numbers that you can't recognize and call you and threaten you. If you come outside, I'm going to do this. I know your car. I know where you live. These are things that you have to mitigate. Listen out for the signs. If you're hearing indication that that person is calling you from a location that is within your workplace, you may want to change the dynamics of the conversation or address the risk concern. The person is calling you and say, oh, I'm downstairs. I'm waiting for you to come to the cafeteria. And then we're going to talk about how you may want to change the dynamics as to how you manage that. Important to know. So there's certainly many do's and don'ts that is important to know. Do stay calm and keep your emotions in check as best as you can. Adapt a non-threatening posture when you're engaging with clients. Let the client air their feelings. Ask open-ended questions. What you don't do certainly is challenge a client by your tone or voice. Turn your back on the client, rush the client, argue with the client, try to disarm a person with a weapon. These are things that you don't do. So I know this is a lot of information, but some of it is familiar to you. Some of it you've consistently utilized. I think I want to wrap up by looking quickly at how do you stay safe during home visits? You want to stay in touch with your office, right? You want to have a sense that your office have a procedure for how you can call in if things get out of line. You want to keep values out of sight so that you're not enticing people in the community. You want to know exactly where you're going. You want to be strategic. You want to park in a well-lit area that's visible and easy to get out of. Be careful about parking and, this is the one parking spot I'm going to go fit in there, and then you have to take 15 minutes to get out or hope that the person in front of you leaves before you can get out. Not a good idea if you're visiting a person in a community. You want to dress professionally and functionally. During the initial visit, you want to discuss mandatory reporting, requirements, and program expectation. So you inform the clients that there's certain things you have to report. So it doesn't become a novelty when you discuss that with that person. You want to notify the client that you have a schedule to keep and you're expected somewhere else. So that if they have any qualms about, keeping you in there longer than you need to, they know somebody will be looking for you. Alarm will be set off. Be wary of others in the apartment. You go and you see strangers in there. You want to be aware of that. You may have to shorten your visit and say, hey, I wasn't expecting for us to meet with people that are unknown. We can do this at another time. Ask about pets and their temperaments. All of us may not be dog lovers or be able to tolerate that. We must be aware of that. Be aware of signs of intoxication. Particularly in close proximity, you're smelling alcohol in that person's breath, you may want to change the nature of your engagement with them. Guard your privacy. Do not give out your personal information unless it's part of your agency requirement and it really suits the purpose. So I know there's a lot we've put out here today. There's a lot of information that really impacts how you look at your own scope of practicing cautionary and thoughtful ways of looking at it, but it's important for you to see it through that lens. And Angela says, sometimes I set an alarm on my phone when I know it's hard to leave, and I tell them it's a reminder for my next appointment. Absolutely. It's important that people have a sense that there's someone looking out for you, someone watching out for you. Because you never, as much as you want to think the very best about people, you have to be conscientious about the fact that, like we said, anyone is capable of violence, regardless of history. Any questions about that? How does that resonate with you? Very good. So I know we've kind of exhausted our time. I want to quickly kind of get to safety planning in a quick way. I think it's important for us to recognize that planning around safety for both yourself and the consumer is critical and important to have them inform the process, inform the way in which we really plan for their concerns and challenges as well as ours. So it's important for us to have, whether it's safety assessment or safety plans in place, and some organizations may have that as part of their documentation. It's important to make sure that that's in place. We want to make sure that we, as an organization, we're promoting that culture of safety. So we want our leaders to value transparency and accountability and mutual respect. We want for us to have that idea that workplace violence is not an acceptable part of the course. It really undermines the culture of safety, and we don't have to accept that as part of our workforce. There are ways of intervening and mitigating and putting some of those risk factors in perspective. We want to make sure that we're reporting instances. We want everyone to see safety as a top priority, as a first priority for them. Because we want to make sure that when you are sacrificing all your time and resources to come to help people who need it the most, you also must have a sense that you're going home safely, that you can leave this work environment and be able to go home to your family. We want to look at those hazardous conditions and those close calls and address them in terms of planning. We want to make sure that we're using careful language to facilitate conversations around workplace violence and to communicate our concerns without fear of reprisal or a lack of responsiveness from all levels of our organization. We want to feel not only a culture of safety, but a culture of responsiveness from our leaders. So think about how does your agency promote staff safety and how that is reinforced, and see from both the research information and from some of the information how you can enhance that, how you can lend more credence to it, how you can contribute to it, and how responsive your organization is. So there's lots of tools and resources available to you. It's important that you recognize them. We'll share that with you, but I certainly want to wrap up by thanking you all. We appreciate your time and attention. And today's webinar was hosted by DBHR through the Washington Healthcare Authority. We'd like to remind you once again that the slides and to the recording is available to you. And don't forget to check out our Foundational Community Sports newsletter for things FCS and upcoming training events. And I want to personally thank you for your time and your sharing. I'm certainly hoping that you got a lot from today's webinar. You were able to get some positive takeaways that you can use to keep you safe and sound. So go forward, continue to do the great work you do, and I wish you safety, and I wish you certainly the great rest of the week. And it's great once again engaging with you. I love my folks from Washington. I'm not going to lie to you. I have my own prejudice with